procedures under local or general anaesthetic, because there'd been quite a lot of inadequately powered historical control type of non-randomised studies that had suggested there was a benefit with local, but it hadn't been tested in any. I mean, some units had already polarised views about doing the vast majority of their procedures under local and weren't involved, but there were still enough units who had equipoise about it, who were prepared. So the anaesthetic technique was either a general anaesthetic, which basically means intubate, ventilate and maintain some sort of physiological normality, or local technique, and the local technique was a combination of infiltration, anaesthesia and deep and super. Perceived benefits of local is that you can do what's called a weight testing, i.e. when the carotid is clamped, you ask the patient to do some simple count to 10, move their arm, move their legs, check basic serivation, and if they deteriorate neurologically, you can then put a shunt in and they'll usually promptly wake up. And clearly we didn't want unnecessarily shunts being put in the local arm, because that was one of the, if you like, tests of the study, or one of the hypotheses was that a lesser use of shunts would actually have a favourable impact in terms of neurological outcome. The primary endpoint was the risk of stroke, MI or death at 28 days after surgery. We also did some longer term follow-up as well, and in conclusion there was no strong statistical evidence to show that one technique was better than the other. There were some sort of interesting trends that can be explored in subgroups of contralateral stenosis and things like that, but the overall clinical message is it doesn't seem to make any difference whether you do the procedures under local anaesthetic or general.